But I want to begin by introducing Dr. Inderjit Mehmi, who will talk about raising the bar in metastatic melanoma and introduce you to some of the first line options that have been there. Dr. Mehmi comes to us from University of West Virginia, and then at some time in the City of Hope network, but with a real desire to make change in cutaneous malignancies. He has joined us and is now a force in bringing multiple trials forward. So with that, I will give the floor to Dr. Mehmi and look forward to his presentation.
Thank you very much, Dr. Hamid, for that. It's a very kind introduction. Thank you to Dr. Pira and Dr. Hamid for bringing me on board. And thank you to Samantha for arranging this patient-oriented symposium. I am hoping to go over some of the first line option as Dr. Hamid mentioned. And hopefully informing everybody what options we have right now for metastatic melanoma, and then subsequent speakers will hopefully tell us where we're going to improve the outcomes even further. So I'm hoping that everybody can see my screen. As Dr. Hamid alluded to, I'm a medical oncologist here at the Angeles Clinic and Research Center. I've been here for about a year, and I exclusively see melanoma patients alongside with Dr. Hamid, and I've learned a great bit from him and Dr. Faris as well. Without further ado, let's talk about some of the numbers in melanoma. So as we know that most of the cutaneous melanomas are early stage and carry a relatively good prognosis over a 5-year period. But the metastatic melanoma patients represent about less than 10% of all of the melanoma. Unfortunately, they carry a worse prognosis, in my opinion, and the data has shown it as well. So this is a recent SEER data analysis that was published this past year. Showed that the 5-year overall survival for melanoma has improved to about 30%. And I think you'd appreciate how that have come about over the years. Because if you look at about 10 to 15 years ago, these numbers were used to, the 5-year overall survival number was below or close to 10%. So we've tripled that survival number over the last few years. And I think to all of the researchers and the clinical trial participant, this is a great feat. So before we go towards how we've improved this overall survival in melanoma, I think it's reasonable to look at what options we had in the past and how good or bad were they. So the first FDA-approved therapy for metastatic melanoma was back in 1975, and it was dacarbazine, one of the alkylating agents that interferes with DNA upkeeps and whatnot. And as you can see, the response rate was less than 15%. And along comes an oral option of dacarbazine, which is Temodar, and in certain situations is still being used, but again, the response rates are very small at best. And the other single agent chemotherapies that tend to target the DNA is carboplatin or the cell division mechanisms, microtubule formation is the Taxol, again, very low response rates. So the natural sort of step towards improving the response rate is to see if we can combine the different types of chemotherapies that could hopefully improve the outcomes for our patients. And That's been done multiple times, a number of different studies. I'm highlighting about 3 studies here that looked at combination of platinum with dacarbazine, or combination of those two with nitrosourea, or addition of tamoxifen to the 3-drug regimen, the Dartmouth regimen. Even though the response rates are much better than single agents, but the durability of the response was lacking. And when you actually look at the single agent dacarbazine and compare it to the Dartmouth regimen that included 4 different agents, there wasn't any overall survival advantage. So we knew that chemotherapy is probably either as a single agent or in a combination format isn't going to be the way to improve these survivals. And we've known from before that, and that's because there's a phenomena of regression that can happen at the local site where the melanoma develops in the skin, that there is an immune function that can be utilized to control melanoma. So from those earlier experiences, the cytokines that our immune system is able to release to activate itself towards various pathogens or neoplastic cells, interleukin-2 experience has been great. So IL-2 high dose format was used in about 270 patients, and it's sort of a continuous infusion over 14 days and 14 doses over 5 days with a rest period, and then repeating the cycle. Unfortunately, it's done in a maximal patient supportive setting, sort of intensive care unit setting, because of the adverse events that come about because of interleukin infusions that tend to be compromising of the cardiovascular system, pulmonary system, possible hepatic injury or renal dysfunction. So in order to sort of monitor those patients, it needs to be done in the ICU setting. But the benefit of this particular approach is that it was able to give us a response rate that was about 16%, which is again not great, but 6% of those responses were complete and durable, long-lasting, well over 5 to 10 years. And that's those graphs that are indicating below that this approach, immunotherapeutic approach, is probably something that we can develop into a much bigger story. So the natural thing is it possible to combine immunotherapy with chemotherapy, label it a biochemotherapy, to see if we can continue to make improvement, albeit small improvement. So there are a number of different regimens that have been tested in small trials. Biggest trial was 114 patients that also showed probably the best response of 60% with the 24 complete responses as well. And some of these are inpatient regimens, and some of these are outpatient regimens where a patient could come to the clinic and be treated and be at home. Again, the response rates are better than chemotherapy or interleukin alone. Toxicity still exists and probably worse than each of those two approaches. So now the question is how to improve the responses, but keep our toxicity to our patients to a minimum possible. So that brings me to the present, and this is from Dr. Allison's work, who's won a Nobel Prize for this, and that story started with the ipilimumab, which is a monoclonal humanized antibody that disrupts how the antigen presenting cells that tend to take the information from the tumor and interact with the T lymphocytes that act against the tumor. And that interaction at times is inhibitory. It doesn't allow the T cell to function properly. And that interaction is between two markers, the CTLA4 and B7. By disrupting that CTLA4 and B7 interaction with this molecule ipilimumab, you're allowing for a more positive interaction between the lymphocytes that are activating and can control the tumor itself. And the second portion of my brief talk is going to talk about the anti-PD-1 antibodies. Again, it's a mechanism to allow our immune system be more active towards the tumor. So as I talked about the ipilimumab, the monoclonal antibody, it was tested in 217 subjects at 3 different doses in a double-blind clinical trial in individuals who had advanced melanoma, failed previous treatments. And as you can see, there are patients who did phenomenally well in a long-term sense. The response rates were still low at the 10 milligram per kilogram dose. The responses were much about at 10 to 11%, but it also came along with significant toxicity that caused injury to the gastrointestinal system or other endocrine systems, potential for injury to the lungs or liver, and skin toxicity as far as rash is concerned. And this is a theme that's going to repeat in most of these trials that looked at immunotherapies. So from ipilimumab, the next step was picking a different marker on our immune system that is interacting with the tumor, and that was the program Death-1 PD-1 ligand. And the first antibody to be tested in this kind of setting was nivolumab, also known as Opdivo. And here, 418 patients who had no mutation present, that BRAF mutation, which I'll talk about a little bit later. And these patients were untreated for metastatic melanoma. At the 3 milligram per kilogram every 2 weeks, they received either nivolumab or dacarbazine, the older chemotherapy that's been used in the past. Here we saw that the response rate was about close to 20% or so, but 6 to 7% of those were complete responses. Again, showing that the immunotherapy in some of these individuals can lead to a long-term durable responses. Okay. Subsequent studies of nivolumab looked at individuals who had already received ipilimumab, or also the BRAF inhibitors that we'll talk about in a little bit. Here, we saw that there was an overall survival advantage when you treated metastatic melanoma individuals with nivolumab compared to dacarbazine. Also showed that there was a progression-free survival advantage, took longer for the cancer to come back if it did. Also, that duration of response was much improved compared to dacarbazine alone. This graph right here. Okay. And here's a small inlet of some of the toxicity that are associated with nivolumab, and they can range from fatigue, nausea, diarrhea, rash, vitiligo, and some of the other uncommon toxicity. But most of the time, this is a well-tolerated approach. If you look at some of the grade 3 or more severe toxicity, they're very small in numbers. Okay. The second molecule that targeted that PD-1 pathway is pembrolizumab, also known as Keytruda. And here, the initial study looked at, in a phase 1 setting, about 540 patients who had already progressed or failed ipilimumab. And they looked at a couple of different dosing mechanism of pembrolizumab at 2 milligram per kilogram or 10 milligram per kilogram versus chemotherapy also. And it was given every 3 weeks. Again, here you see that with those pembrolizumab, either at 2 milligrams or 10 milligrams, you're definitely doing much better than chemotherapy. Your adverse event or toxicity profile was much better. There's an overall survival and progression-free survival benefit, and almost all of the patients that you see here in a forest plot benefited from the pembrolizumab approach rather than the chemotherapy. And the side effect profile is very favorable. Most of the time, fatigue, some arthralgias, myalgias are some of the concerns. In rare cases, you can have significant toxicity that is in the GI system or pulmonary system or other skin toxicities. And so so this was one of the phase 3 study that I wanted to highlight. It's the KEYNOTE-006 study that looked at pembrolizumab, comparing it to ipilimumab in advanced melanoma. Again, it's a phase 3 study that looked at pembrolizumab every either 2 weeks or every 3 weeks versus ipilimumab at 10 milligrams given every 3 weeks. A large study of 834 subjects, and they were well balanced between the arms. Again, at 6 months, there was an amazing progression-free survival advantage of 47.3% with every 2-week pembrolizumab and 46.4% with pembrolizumab at every 3 weeks, and where ipilimumab's 6-month PFS or progression-free survival was only 26.5%. And again, at 12 months, overall survival was 74% with pembrolizumab and 68% with every 3-week pembrolizumab, and IPI was at 58. Now, there's been update to this data for a number of years now, and it's shown that these benefits are sustained with pembrolizumab. And that this data actually led to the approval of pembrolizumab at Q3 weekly option or every 3 weekly option that actually we use quite a bit in our clinics. So, excuse me. The next, we saw some improvements in metastatic melanoma when we use anti-PD-1 agents such as nivolumab and pembrolizumab, but we're still not capturing a good population of those patients. Roughly with nivolumab or pembrolizumab alone, you're capturing only about less than 20% of the patients. So how can you make these treatments available and benefit more patients? And with that in mind, the Checkmate 067 study was carried out. And this particular trial looked at ipilimumab, which is the anti-CTLA-4 antibody we talked about a little bit earlier, and nivolumab, which is the PD-1 antibody, and compared it to ipilimumab alone. And in this trial, actually, there were 3 arms that 945 patients were divided into. One arm got nivolumab alone, another arm got, another cohort or arm got ipilimumab and nivolumab, and one arm got the ipilimumab, which was the control arm. And these were the unresectable or advanced melanomas, and the key point that they wanted to analyze was progression-free survival and overall survival. At the first publication of the study, overall survival wasn't reported because study wasn't mature enough, but the progression-free survival was definitely seen with both the combination arm and nivolumab alone arm versus ipilimumab, as shown here in the graph. Again, here in the inlet, you see that the responses were much better with both these options versus ipilimumab. And one of the other things that I should point out is the toxicity with the combination approach was a bit higher compared to nivolumab alone, and somewhat similar to ipilimumab at 10 milligram per kilogram. Okay. This is the highlight of the some of the toxicity data that I talked about. And this is the 5-year update showing that even at longer follow-up, at 5 years, the overall survival advantage is there for the combination and the nivolumab alone compared to ipilimumab. And same thing for progression-free survival. And they also looked at the patients who carried a BRAF mutation. Did they have any disadvantage from the immunotherapy combination? Actually, both of the population, the BRAF mutated or unmutated, had similar benefit with the ipilimumab and nivolumab. The other option is oncolytic virus that sort of intratumoral injections that we tend to use at certain times to see if we could activate the immune system. And one such approach is TVEC. That's shown progression-free survival and overall survival advantage, very tolerated. Number of other trials are ongoing to see if we can combine this option with other immunotherapies to improve the outcomes. A little bit that I will talk about is the BRAF mutation that happens in about half of all of the metastatic melanoma. There are two predominant mutations, the V600E and V600K, tend to be in a non-chronic sun-exposed area. We know that the BRAF mutated patients definitely do worse than the others. There have been 3 different trials for 3 different combination approaches that have shown overall survival advantage versus chemotherapy or single agent BRAF inhibitors. And these tend to be very tolerable overall and predictable toxicity. And we're able to use these fairly routinely in our BRAF mutated patients. I hope I was able to summarize some of the treatment first-line therapies that are available. And I'd love to answer any questions at the end when we have some time.